Hi everyone, it's a great pleasure to be here, and I'd like to start by thanking Imogen for the invitation to speak. And I hope that in the next 15 minutes or so I'll be able to demystify a little bit some of the terminology that you find on a melanoma pathology report, and also just give you a little insight into what actually happens to tissue biopsy samples taken for melanoma diagnosis. So just to start off with, I thought I'd just clarify what exactly is a pathologist and what do pathologists do, because there is a bit of confusion about this. We are medically qualified doctors, and we have quite a unique position in the hospital because we work at the interface between the clinic and the lab. And what our role is to examine tissue and cell samples from patients in order to diagnose disease. And a large proportion of our work involves the diagnosis of cancer. So in terms of tissue samples taken for melanoma diagnosis, what we generally will receive from the surgeon is an orientated piece of skin with the lesion in the center. It's orientated with the suture, and we actually spend quite a lot of time describing what we can see before we prepare the sample for examination under the microscope. And what we do is we ink the various margins around the specimen with a special dye that we can see under the microscope. And then we slice the tissue very thinly, and what we're looking for is to try and see how deep into the skin the lesion on the surface is invading into. And we then place the slices into plastic cassettes, which are then processed overnight to dehydrate the tissue, and then they are embedded in paraffin wax to form a tissue block like this. The paraffin block is then trimmed extremely thinly to produce very thin, delicate slices, which are then mounted onto glass slides and then stained with dyes so that we can visualize the cells within the tissue. So these are examples of what we see under the microscope. These are melanoma tumors that have been stained with dyes, and these we can see the cells forming the tumors. And the reason that I've put this slide up is just to show you how incredibly variable in appearance different melanoma tumors can be. You can see these four all look very different from each other, and because of this, melanoma diagnosis is actually one of the most challenging areas in the whole of diagnostic pathology. So whenever we sign out a report of a melanoma diagnosis, we will often have at least 2 consultant pathologists signing out on that report to be absolutely crystal clear of the diagnosis. And many of these are discussed at consensus meetings with a number of consultants together. So in terms of the report that we produce, what do we need to include? Well, of course, we need to include a diagnosis, and then we need to give some important information with regard to prognostic factors regarding the tumour. These include grading, which isn't really done particularly for melanoma, but certainly for other types of cancers it's very important. Staging, which refers to how far the tumour has spread, both into the skin locally, then to local lymph nodes, and then distant metastases to other organs. And we use the TNM system. Of course, excision is extremely important, so has the tumour been completely excised? And we give a distance to all the margins. And increasingly now, because of modern sequencing technologies and advances in molecular techniques, we're being asked to provide information about specific molecular biomarkers as well for many tumours. And these can vary depending on the tumour type to be either the presence of a particular protein or the presence of a particular mutation. And all this is done is to ensure that we give our clinical colleagues all the information they need to provide the most appropriate treatment for the patient. So I thought, before I go any further about talking about the various terms you might find in the report, I need to mention the Tissue and Data Set Pathways section of the Royal College of Pathologists website. This is a publicly available resource that has far more detail than I'm going to be able to give in this short presentation. And it can be accessed at the Royal College of Pathologists website. I have a few copies with me as well if anyone would like to look at one after this presentation. And in these tissue data sets, there's one specifically for melanoma. This includes everything that pathologists are required to include in their reports. It's a national guidelines document. And pathology departments around the country use it as guidance for auditing the quality of their reports to ensure they meet the high standards set by the college. So this is what the document looks like on the website when you come to it It is due for a revision very shortly, I should add, so all the information I'm giving you today is correct, but we are expecting an update very soon, so things may change slightly. So what is included in the data set for melanoma? Well, it's split into core data set items and non-core items, and the core items are those information that we need to give which gives the most important information for the staging and prognosis of the tumour. It also includes details about how the samples should be handled and processed in a pathology laboratory as well. It also includes some non-core data items, which are generally included in most reports, but can vary between centre to centre depending on departmental preferences and any local research projects that are going on in that centre. But despite all this sort of plethora of information that we're asked to provide, there's unfortunately yet no standardized way in how to present it. So the reports can vary quite drastically in their appearance between departments. Some departments may have a table with all the information slotted in, whereas other departments may have a long descriptive paragraph. And I think that can be quite confusing if you've received treatment in a number of different centres and you're presented with quite varying appearance of pathology reports. So this is the list of the core data set items that are essential to include in any pathology report for melanoma. And you can see it's quite a long technical list. So if I was to say, to sort of prioritize, if you wanted to think about the most important information to take away from this, if I just highlight these three factors in red, the Breslav thickness, the presence or absence of ulceration, and the mitotic index, as probably the most important ones to remember, because these three factors will directly influence the staging of the melanoma, particularly the T stage. And of these three, it's really the Breslav thickness that is the most crucial. So I'll be talking through all these, but this table here just summarizes how this T stage varies depending on these variables. So the first of the core data set items is the subtype of melanoma. And there are quite a few different subtypes, but broadly the two most common categories are the superficial spreading subtype and the nodular subtype. The superficial spreading subtype appears like this and generally has a very irregular border with variable pigmentation. And when we examine these tumours under the microscope, what we find is that most of the tumour cells are found in the most superficial layers of the skin. They haven't invaded that deeply yet. And therefore, this subtype is associated with a better prognosis than the nodular subtype, which on appearance on the skin is a palpable lump. And when we examine this type of melanoma under the microscope, it generally has already invaded quite deeply and therefore, unfortunately, is associated with a worse prognosis. The next data set items are the Breslav thickness and the Clark level. And broadly speaking, these two refer to the same thing, which is how deep into the skin has the tumour invaded. The Breslav thickness is a vertical measurement in millimeters, and the Clark level is a description of the deepest layer of the skin that has been invaded by the tumour. And both of these are important to include in the reports because they will determine the pathological T stage. The Breslav thickness is also very important because tumours that have a Breslav thickness of greater than 1 millimetre will be recommended to have a sentinel lymph node procedure. The next core dataset item refers to the growth phase of the melanoma, and this really is restricted to the superficial spreading subtype of melanoma because all of the nodular melanomas are thought to be already in vertical growth phase. So the growth phase is split into either radial or vertical, and tumours that are in radial growth phase have all the cells in the most superficial layer of the skin, and we're not seeing any evidence of early signs of invasion deeper or increased cell divisions or proliferation of the cells in that tumour. Whereas the vertical growth phase tumours are, although more superficially located, are starting to show signs that they're beginning to invade more deeply or behave a bit more aggressively, and therefore the vertical growth phase tumours are associated with a poorer prognosis. But this can be quite tricky to assess sometimes, and that's why we often do need the input of more than one consultant pathologist to be sure of the diagnosis. The next two items we need to mention are ulceration and mitotic index. So ulceration refers to whether or not the tumour has broken the surface of the skin, And the mitotic index refers to how actively dividing the cells are within the tumour. And we can recognize this by these dark black spider-appearing figures within the tumour. And we count these, and the greater the number of these, the more actively dividing the tumour is, and the poorer the prognosis. The next two factors are lymphovascular invasion and perineural invasion. Lymphovascular invasion refers to whether the tumour has invaded a blood vessel. You can see here this is a tumour sitting within a blood vessel with red blood cells. And perineural invasion refers to whether or not the nerves locally to the tumour have been invaded. We can see a nerve here surrounded by tumour cells. And both of these are associated with a poorer prognosis. The next prognostic factor we have to mention is whether or not we have microsatellites present. These are additional tumour deposits separated by normal skin from the main tumour. We can see the main tumour here, some normal skin, and then a microsatellite deposit. And these can influence the end stage of the TNM staging if they are present. Another feature we need to comment on is the presence or absence of regression. This is when some of the tumour cells disappear and are replaced by areas of scarring and inflammation. And it's a slightly controversial entity, but generally it's felt that large areas of regression are associated with a poorer prognosis. So we need to comment on it if it is present or not. The next prognostic factor is the presence of tumour-infiltrating lymphocytes, and this means whether or not we see cells of the immune system within the tumour. And we comment on whether the pattern is brisk, which means there's lots of cells, or non-brisk, which means there's only a few cells. And generally, the tumours that show a lot of immune cells within them are associated with a better prognosis because the immune system is actively attacking the tumour. The next factor we need to mention is margins, and of course we mentioned the deep and peripheral margins. And of course, after the initial excision, we always undertake a further wide local excision, and that scar is entirely examined under the microscope as well. The final factor we need to mention is the presence of lymph node involvement. So this is a lymph node here, entirely replaced by pale tumour cells. And we talk about the size of the deposit and also whether or not the tumour has spread outside the lymph node into the surrounding tissue. In terms of the non-core data set items, this is where we can mention molecular tests if they have been done. This may change to be a core item in the future, and also a description of how the tumour look and special stains we use in order to measure the depth of invasion. And again, this will vary slightly from centre to centre. So I'd just like to finish there, and I'll just mention an initiative I'm involved in, which is run by the NCRI called CMPAT, and the purpose of this initiative is to increase patient and public awareness of the role of pathologists in patient care and cancer research, and also to try and maximise opportunities for tissue-based research involving pathologists across the NHS. So this is the website address here if you're interested in finding out any more about the initiative, and thank you very much for your attention.